Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more. Hello everyone, I'm the Millennial Mechanical Therapist, and today I want to talk about manual therapy in conjunction with MDT. Now, I use the word conjunction, but that's because everyone has a little bit, no, I shouldn't say everyone, but most people have this kind of misconception that MDT is really just hands-off therapy. This is just exercises. This is trying not to get the patient dependent on you. Now, those are important tenets that I think are things that we should be encouraging in our profession. We should not be creating a patient dependency. We should be empowering our patients and using more exercises rather than passive modalities or passive treatment techniques. However, I want to kind of clear the air about this misconception with some of my colleagues that MDT just doesn't use any manual therapy. Now, I will, through a couple case studies here, very quickly and briefly, I'm going to tell you that daily, hourly, I use manual techniques. They may not be the most extravagant ones. They may be pretty basic and simple, but they're effective because of the structure of progression of forces. These manual techniques become very helpful for the patient and truly try to reduce the amount of dependency because like typical manual techniques, the idea is apply it, try to get things to free up a little bit more, and then return to an exercise that a patient can perform themselves without you to maintain their benefits. Now, a previous case study that I worked with on an older woman with left-sided low back pain that went to her left hip buttock. In that instance, she required a lateral overpressure during repeated extension and lying. She required it to be in the position where I was kind of shifting the hips over with the ribs, so I'm doing a counter force there, trying to get a little bit more lateral pressure in that plane of movement there. We had to go through about 2 sets of 10, maybe 3 sets of 10 if I recall correctly, before she was able to perform repeated extension lying with hips offset without overpressure to continue getting benefits from that exercise. Yesterday in the clinic, I was working with a gentleman who was performing a retraction exercise, and he had benefited from that in the initial evaluation. We centralized pain from the outside of the shoulder to the neck, and at this visit, he said, I've been doing this for about 4 or 5 days now, and I feel like I'm kind of plateaued. I feel about the same. So what I had him do is I had him go through self-overpressure, a little bit more there, and he didn't get any benefit out of it. So what I went to from there, I came in and I gave him the retraction overpressure as he was going through, and he started to decrease his symptoms and remain better from that. We didn't clear his symptoms out, so I may even have to add more pressure or get him onto an extension exercise because of his directional preference. But that manual technique came in right as it was needed during that force progression. In a different example, treating for the extremities, I had a young woman come in who had shoulder pain that was very diffuse. She didn't give me a good pain pattern with it. She just said, my shoulder hurts around here. After a few days of mechanical assessment, we found that her reductive strategy was having the arm in flexion, abduction, horizontal abduction, and externally rotating. So that ultimate movement would be external rotation there. As I sent her home with that, she said she was getting benefits from it, and it was maintaining her symptoms throughout the day at about a 3 or 4 on VAS compared to an 8 when she came in. Now, the day that she presented that I speak of with the manual techniques, I brought her in and she said, I'm doing it, and she was unable to get enough reductive force to really get the benefit out of the exercise. So I came in and I used manual technique of trying to get not only just overpressure or passive range of movement on that, but I was also doing some inferior inferior gliding of the glenohumeral joint there. Coupling those two motions, she had a reduction of her symptoms to a 0 to 1 out of 10 on VAS in that office visit. The last case that I want to explain is a woman that I'm seeing currently. She came in with complaints of low back pain, and she said that she's been having pain mostly in the center now that I've been seeing her for, I think this was her third visit that she came in, and she said it's sticking right in the middle. It came out of her leg up to the low back, and now it's kind of right on the spine, and it's just sticking there for the last few days. So what I had her do was repeated extension and lying, and I gave her some posterior and anterior mobilization or some pressure there to give her some overpressure. As I'm doing that, her symptoms reduced and abolished. So I want to kind of clear the air and make it very, very just open that MDT isn't just exercise. It's not only having the patient do for themselves. That's a huge tenet of it, but sometimes manual therapy is necessary. So you want to make sure that you bring that in when it's appropriate in that force progression. Take that away and take it to your clinic when you go in tomorrow morning or next Monday, whatever it is. Remember, everybody, move early, move often, move to end range, because that's where the magic happens.